All right, let's get into it. When we think about the colon, most of us just picture a simple tube, right? The last stop on the digestive highway. But honestly, its function and all the ways it can go wrong are incredibly complex. So today, we're going to pull back the curtain on this vital organ and take a journey through some of its most critical diseases. And that really brings us to the big question, doesn't it? Is the colon just simple plumbing? Or is it this sophisticated system where the original blueprint can be flawed, the walls can get inflamed, the flow can get blocked, and the cells themselves can just go rogue? Well, as you're about to see, it is absolutely the latter. So here's our game plan. We're going to start with problems that are there from birth. Then we'll move into inflammation, issues with the structure, and then the really crucial topic of polyps, before we finish up with colon cancer. You can kind of think of it like we're climbing a ladder of severity, from these foundational flaws all the way to the most serious outcomes. First up, foundational flaws. We're talking about congenital disorders here. This means the colon's blueprint was just a bit off right from the very beginning. Now, these are pretty rare, but they teach us a ton about how the colon is actually supposed to work. Check this out, two really distinct developmental errors. With Hirschsprung disease, some critical nerve cells just don't form, which leads to this functional blockage in newborns. Meckel's diverticulum, on the other hand, is a little leftover pouch from when you were an embryo, and it can cause bleeding later in life. See? Two different blueprint errors, two totally different problems. Okay, let's move on to our next big category, inflammation and infection. This is where the colon isn't built wrong, but it comes under attack, either from something outside or, in a wild twist, from the body's very own immune system. And this brings us to what might be one of the most important concepts in gastroenterology, the difference between IBD and IBS. It all boils down to this. Can we see actual structural damage, or is it a problem with the function where everything looks normal? Getting this right is absolutely critical for patients. This table just lays out the two types of IBD perfectly. For ulcerative colitis, or UC, the keywords you gotta know are rectum and continuous. It starts at the very end and just spreads backward in one unbroken line of inflammation. But Crohn's, that's patchy. It has what we call skip lesions, and it can pop up anywhere. And look at the depth. UC is pretty superficial, but Crohn's is transmural, which means it goes right through the entire thickness of the colon wall. So here's the bottom line. Think of ulcerative colitis like a continuous burn, maybe like a bad sunburn that starts at the rectum. And think of Crohn's as deep, separate cracks in the pavement. It's that cracked nature that leads to all those nasty complications like strictures and fistula. And to help you lock this in, here's our first little memory trick. For ulcerative colitis, just remember the word ulcer. Ulcers, continuous inflammation, erythema, which is just redness, and the rectum is always involved. See? Simple and it works. And for Crohn's disease, you guessed it, we have Crohn. Cobblestone look, rectal sparing is common, obstruction from those strictures, histiocytic granulomas if you look under a microscope, and often non-bloody diarrhea. Use these two and you'll never mix them up again. And that brings us right back to IBS. So after a doctor has looked for and ruled out all the structural damage we just talked about with IBD, they might land on a diagnosis of IBS. It's what we call a diagnosis of exclusion. The pain, the bloating, it is all 100% real. But the cause is a disruption in function, not something you can see. All right, time for section 3, structural and flow issues. Honestly, the easiest way to think about these is to imagine we're dealing with plumbing problems. Either the wall of the pipe itself gets weak, or the blood supply flowing through the pipes gets messed up. So a classic plumbing problem is diverticular disease. Diverticulosis, that just means you have these little pouches in your colon wall. Super common. The real trouble starts with diverticulitis. Anytime you see itis, that means inflammation. This is when one of those little pouches gets blocked up and infected, and that's what causes the pain and fever. So osis is just having them, itis is when they cause trouble. Big difference. The other side of the plumbing equation is flow. With ischemic colitis, the blood flow to the colon gets cut back and the tissue starts to die. This happens a lot in what we call watershed areas. Think of them as being at the very end of the supply line. Angiodysplasia is different. It's not a blockage. It's just these fragile, swollen blood vessels that can break easily and bleed, especially in older folks. Okay, everybody, this next section is a huge fork in the road. We're talking about polyps. These are the warning signs. This is that critical moment on the path from a healthy colon to a cancerous one. Seriously, understanding polyps is the key to understanding cancer prevention. This slide really breaks down the two main players. On one side, you've got hyperplastic polyps. These are usually small, and here's the key. They have zero potential to become cancer. On the other side, we have adenomatous polyps. These are the ones we really have to watch out for. They're what we call neoplastic, meaning they're a new, abnormal growth, and they carry a high risk of turning malignant. And within that risky group of adenomatous polyps, there is one pattern you have to remember. It all comes down to this simple but vital little phrase. Villus equals villainous. That villus pattern has the highest potential to become cancer. When a pathologist sees that under the microscope, all the alarm bells start ringing. And that, of course, leads us to our final section, decoding colon cancer. This is what happens when those cellular blueprints go completely rogue, when the warning signs are missed, and a polyp makes that full, dangerous transformation. This shows this step-by-step genetic cascade so clearly. This doesn't happen overnight. It's a chain reaction. It starts with losing a protective gene called APC, which lets the polyp form. Then a mutation in a growth gene, KRAS, makes it get bigger. And finally, you lose a guardian gene called P53, and that lets it become a full-blown carcinoma. It's a predictable, multi-step process. So who's most at risk? Well, as you can see, the single biggest risk factor is the very thing we were just talking about, adenomatous polyps. After that comes chronic inflammation from IBD, a strong family history, and then lifestyle stuff like a low-fiber diet, obesity, and smoking. It's really a mix of your genes and your environment. Now, this is fascinating. Where the cancer grows completely changes the story it tells. Right-sided cancers tend to grow into these big, bulky things that bleed slowly, causing stuff like fatigue and anemia. But left-sided cancers? They tend to grow around the colon, like a napkin ring, squeezing it shut and causing blockages and changes in bowel habits. Same organ, two totally different presentations. But here's the good news. We can absolutely fight back. We have powerful screening tools like colonoscopy and simple stool tests that can find those polyps before they ever become cancer. And one really important note here, that blood test, CEA, it is not a screening tool. We only use it to monitor how a patient is responding to treatment after they've already been diagnosed. And that leaves us with one last thing to think about. We've just walked through the clear, step-by-step path from a harmless polyp to a life-threatening cancer. So knowing that, is a screening colonoscopy just another medical procedure? Or is it something way more powerful? A way of literally looking into the future and changing what you see?